Namaskaram everyone. Here we shall be talking about the salient updates of the neonatal resuscitation program guidelines given in October 2025, along with a corresponding recap of what we were practicing till now, that is the 8th edition. There are some changes important primarily from theoretical point of view, and these have been summarized in a single scene here as changes in algorithm. The first thing is that the terms birth and initiate cord management plan have been included in the first golden minute itself. The next thing is that suction has been removed from the text box of routine care while it was mentioned earlier. And the last thing is that the term ventilate is now to be used in place of the term positive pressure ventilation used earlier. Initial cord management plan, as per my understanding, would include early cord clamping, deferred or delayed cord clamping, and umbilical cord milking. Deferred or delayed cord clamping is done in vigorous term and preterm newborns who do not require immediate resuscitative measures and be shifted to the warmer, resuscitation warmer. So its duration has been increased from an earlier at least 30 to 60 seconds now to at least 60 seconds, giving more time for the maternal blood to reach the neonatal circulation. This point should definitely be communicated to our obstetric fraternity as well. In non-vigorous term and preterm newborns with gestational age between 35 to 42 weeks, umbilical cord milking may be considered as a reasonable alternative to early cord clamping, but it is not recommended in less than 35 weeks due to the risk of intraventricular hemorrhage. Initial FiO2 to be used for resuscitation in newborns with gestational age more than or equal to 35 weeks was 0.21 or 21%, and that for less than 35 weeks was 21% or to 30%, that is 0.21 to 0.30 as per the earlier guidelines. This has been further broken down into 21 to 30% for gestational age between 32 to 34 weeks and more than or equal to 30% for gestational age less than 32 weeks, even though grossly the recommendations stay the same. Target ventilation rate has been expanded from an initial 40 to 60 breaths per minute now to 30 to 60 breaths per minute. Target SpO2 table now begins at 2 minutes of age instead of an earlier 1 minute of age, and this practically appears to be more just since 2 minutes time may just get lapsed in attaching the probe and securing the uniform pulse waveform. Initial peak inflation pressure of 20 to 25 centimeters of water, which was earlier applicable to all irrespective of gestational age, is now recommended for less than 32 weeks only. For more than or equal to 32 weeks, we can use PIP of 25 to 30 centimeters water. Ventilation corrective steps need to be performed if heart rate continues to be less than 100 per minute, even after 15 to 30 seconds of initial ventilation. Earlier, this figure was only 15 seconds. These steps were categorically defined by the mnemonic Mr. SOPA, that is mask readjustment, repositioning the head, suctioning the airway, oxygenating, increasing pressure, peak inflation pressure, and putting in advanced airway. Moreover, the order of performing these steps need not necessarily be MRSOPA. It can be decided by the resuscitator himself. For example, one can reposition the head and suction the airway before readjusting the mask. Laryngeal mask airway can be used head-on as a primary airway instead of a rescue airway device, that is, instead of using the face mask initially for giving positive pressure ventilation. Weight bands for deciding the size of endotracheal tube have now been simplified and mentioned in grams instead of the earlier in kilograms, and the gestational age less than 28 weeks has further been broken down into 22 to 25 weeks and 26 to 28 weeks respectively, even though the size of endotracheal tube stays the same for both. We know the depth of endotracheal tube to be inserted is roughly equal to the size or the internal diameter of the endotracheal tube into 3. So till now we practiced that this depth should correspond to the baby's lip. But now it says that the depth should be adjacent to anterior edge of the baby's upper gum in midline, that is slightly deeper than what we've been doing till now. So to summarize, birth and initiate cord management have been added in the algorithm in the first minute, suction has been removed, and instead of positive pressure ventilation, we are using the term ventilate. Target SpO2 table to begin from 2 minutes, ventilation rate 30 to 60 breaths per minute, and initial PIP average 25 centimeters of water have been specified. The laryngeal mask airway can be used as a primary ventilation device instead of the face mask. The ventilation corrective steps, the timing and order has been redefined, and the size of endotracheal tube has been specified further, as well as the depth of endotracheal tube should now correspond to the anterior edge of the maxillary gum of the newborn in the midline. Once again, thank you so much for your love and appreciation. Please do continue. Namaskaram.